Hello everyone, welcome back to my channel. So today I will be talking about surgery in a case of a brown cataract under topical anesthesia, and I will be discussing each step of the surgery one by one. So the main port is created with the help of 2.8 mm keratosis, and the blade is first moving horizontally followed by the vertical tilt of the blade, which is followed by the intracameral injection of the phenocane to anesthetize the iris and to keep it dilated due to the effect of tropicamide, phenylephrine and lidocaine. Now, 0.06% of trypan blue dye is injected into the anterior chamber to stain the anterior capsule, which is then washed out immediately as the dye is endotheliotoxic. And other dye which can be used for the same purpose is the indocyanine green dye. Before injecting the dye, you can also use air bubble to prevent the toxic effect at the corneal endothelium. Now, 2% HPMC is injected into the anterior chamber and over the epithelium of the cornea. Now the capsular access is initiated with the help of 26 gauge cystitome, and I'm using my left hand to stabilize the globe. The size of the capsular access is to be decided on the basis of the grade of the cataract. So for this grade of the cataract, I am aiming for around 5.5 millimeter of the capsular access. You can also use capsular access forceps or the micro forceps for the same purpose. Now the capsular access is of adequate size and is completed now. Now here I am proceeding with the hydro procedures like hydrodissection and hydrodelineation. Hydro procedures in these hard cataracts should be done very gently and judiciously because they may be associated with the intraoperative capsular bag distension syndrome, which may lead to rupture of the posterior capsule. So it should be associated with gentle tapping at the center of the nucleus. Now let's proceed with the emulsification of the hard nucleus. Here I am using Otley Cataracts 3 machine, and the tip is the flared type of tip. So this tip is very useful for holding the nucleus and to perform direct chop. Here I am aspirating the loose cortex to have a clear view on the central bulky part. Here the phaco tip is completely buried into the central core of the nucleus, and here we go with the first chop. And the chopping is done under the burst mode, which will give you a good hold on the nucleus. And the nucleus is rotated at 90 degree and the second chop is performed. Although the posterior plate seems to be attached, but I will try to separate them in further chops. Here my aim is to perform at least 5 to 6 pieces of the nucleus. After few more attempts, I am able to see the separation of posterior plate fibers. Here I am holding the partially separated pieces and trying to break the posterior plate. And this maneuver is repeated again and again. After ensuring that all the pieces are separated, OVD need to be replenished. And now emulsification and aspiration of these pieces is to be done. And we need to remember that this step involves the maximum utilization of the ultrasound energy. So that's the importance of replenishing the OVD. At at this step, I asked my assistant to change the mode of the machine from burst mode to the pulse mode. And each of the fragment is taken out from the capsular bag and then emulsified and aspirated. One more thing I want to highlight is you need to keep your probe at the pupillary plane, not above it, not below it. And here we are done with the last piece also, which is being emulsified. And now only the epinuclear sheet is there, so it is also then aspirated. Now a good glow with intact posterior capsule and few cortical fibers is seen. And aspiration of the cortical fiber, and final cleaning is done with the help of bimanual irrigation and aspiration cannula. Now the final polishing of the posterior capsule is done to remove the cortical debris from the posterior capsule, and implantation of intraocular lens is done. I'm doing hydroimplantation in this case, and which is IOL is gently put into the anterior chamber with dialing of the optic into the capsular bag. And we are able to see that the haptics of the IOL are tightly attached to each other, and I'm trying to detach them with the manual bimanual irrigation aspiration system, and they are separated. So OVD removal and final positioning of the IOL is done, and the case is completed. I'm hydrating the wounds of the cornea. Thank you so much for watching the video.